and it's not very calm, I'll just beg on you that you try to follow up with the little time that I will be talking and bear with the noise. It is already 5 minutes after 2 p.m. and I think we can go ahead with our session. Thank you so much, the Keiko team. I am Manju Florence, and like I said, my internet is not very to know if you are getting me well. Can you get me, please?
Yes, we can. Thank you, Florence.
Yeah, we are getting you.
Okay, if you are getting me, then I can continue. You're welcome to this great session of today, and this is our first session for the 2026 African Cancer Research and Control ECHO. And we are happy to welcome everyone who is here. And we hope that you're going to actively participate, especially in the discussion session, so that we can have the most of this session. Like I earlier mentioned, my name is Manju Florence, and I'm moderating this session. I am the supervisor of the Women's Health Program for the Cameroon Baptist Convention Health Services. And I also serve as the Secretary General for the African Organization for Research and Training in speaking on human rights in cancer care. We are going to be looking at the intersecting law, the policy and clinical care to close the cancer gaps. Please, can you still get me?
Yes, we can. Thank you.
To be sure, since my network is not very stable. And this is going to be a 1 hour, 30-minute session. And just for some quick reminders, we are going to encourage that everyone should mute your phone or your computer or your set. You mute your microphone if you are not speaking. And for the sake of the bandwidth to permit us, please, we would really prefer that you turn off your videos so that our session can be better. And we really encourage that it should be interactive. And we encourage that you can use the chat box and send your questions, you introduce yourself, or you make any comments using the chat box. And we enable subtitles on your screen as needed. The sessions, as you all know, are going to be recorded, so we can have these sessions even afterward. Okay, just to get some sessions objectives. We want to strengthen the participants' understanding of
Florence, we've lost you there. Nancy, it seems we have lost Florence there in terms of the introduction. I wonder if we shouldn't just continue with the program. Is there anyone that can, in the meantime, act as a moderator? If not, I can. I see Dr. Samuel is online. I'm not sure if he's able to take over moderation. Samuel has also disappeared. Good afternoon, everybody. I think in the interest of time, and just to get the session underway, let us start. I think by now everybody has been able to read the objectives of the session. In the session where we are focusing on human rights and cancer care. A very warm welcome to everybody that has been able to join us thus far. It is the first session of the year, and as we know with the session, with these sessions, we do have extreme difficulty sometimes in terms of bandwidth, as well as connectivity. So, it is, in fact, people do fall off, the call, and we just have to step in. So it is actually a little bit, I would want to say, unusual for me to also do the opening remarks here, as I am a case presenter. However, I am also part of the steering committee. So from my side, thank you very much indeed for attending. And then if we could immediately move into our speak. I just need to pull up, if we can. Our case presenter is Khanyisa Mapipa. For me, she's well known. She's an activist attorney and heads the health rights program at the Law Centre Section 27 in South Africa. She holds a BCom Law and an LLB degree from Rhodes University and is currently pursuing her LLM in Human Rights through the Centre of Human Rights at University of Pretoria. So Khanyisa has 9 years post-articles experience as an admitted attorney to the High Court of South Africa, in which time she has worked both in the public as well as the private sector, including the South African Human Rights Commission. She's a Mandela Washington Fellow, alumni of the Foundation of International Understanding through students from the University of Washington. And she's also a recipient of the 2023 Mail and Guardian 200 Young South African Recipients Award. Current areas of expertise include sexual reproductive health, oncology services, migrant health, and emergency medical services. It is my pleasure then to introduce to you Khanyisa and to give her over to her to provide a didactic presentation on the human rights and how and where that fits in with health care and specifically with cancer care. Thank you, Khanya.
Hello. Thank you, Salome. Thank you to the hosts for having me. As Salome mentioned, my name is Khanyisa Mapipa. I work out of Johannesburg, South Africa, at an organization called Section 27. And Section 27 is a law center that specializes in the right to access healthcare and access education. We also do advocacy work as well as obviously litigation and other legal research as well. So Salome, I came to know Salome through our landmark case, as some have called it, the Cancer Alliance versus the member of the executive committee in Gauteng, which is where I'm based in Johannesburg, around access to cancer radiation oncology treatment in the province, where about 3,000 people were awaiting services and had no hope of getting those services without the Cancer Alliance's intervention, and we represented them in that case. I will be speaking to some slides, so I'm just going to share my screen. Just going to share my screen quickly. Can you see my presentation?
Not yet. Has she got sharing rights there, Nancy Kincup? Otherwise,
I think we can see, but we are seeing the poster.
Yeah, we're seeing the poster at the stage of the game, so we're not seeing Kanye's screen.
Let me try again. Is it visible now?
Yes. If you could just
Yes,
go
it is.
presentation mode, thanks, Kanye.
All right, perfect. Okay, all right. So the title of the presentation is Human Rights in Cancer Care, which is why we've gathered here today. So the mode of the presentation, I will be speaking from a South African context, obviously because that is where I practice and have the most experience. But I will try as much as possible to give examples or to explain things in a way that can be applicable across our borders. So the right to access healthcare services, or the right to cancer treatment, falls under the right to access healthcare services, which is a right that is guaranteed under the African Charter. Sorry? Which is a right that is guaranteed under the African Charter on Human and People's Rights. So this particular article, Article 16 in the African Charter, specifically mentions that everybody has the right to and to enjoy the best attainable state of physical and mental health, and that state parties who are signatories to the Charter shall take the necessary mechanisms or measures to protect the right to health for their people, and to ensure that their people get access to medication and medical attention when they're sick. So we know that that these rights exist. Many constitutions throughout African countries have these rights in them, particularly the right to access healthcare, and it is in that way brought to life through various legislation in many countries. However, the reality, as is very, very similar in South Africa, is that the right itself is not actually realizable, or is not actually realized. It is realizable, but it's not actually realized. And what happens most of the time is that the state will say, or the various states will say that they have limited resources. In specifically the South African context, Section 27 of our Constitution is the section that gives rise to the right to access healthcare services, and in it giving rise to the right to access cancer care. And in the section, it specifically says that everyone has the right to access healthcare services. However, the hurdle that we have often had to overcome as human rights attorneys in South Africa, particularly those focusing on this right, has been subsection 2 of our Constitution, which basically says that which limits the applicability or the realizability of this right to available resources. So what that says is that where the state does not have the necessary resources, whether it be personnel, machinery, medication, hospitals, radiation machines, whatever it is, where the state does not have the available resources, that right can be limited in that way. And so this is the hurdle that we've had to time and time again when litigating this topic have had to succumb, because we are dealing obviously with the right to healthcare, which is so linked to the right to dignity and the right to life. It's obviously paramount that we try as much as possible to create precedent that allows us to limit as much as possible the exception of available resources in this particular context. But as I was saying, this is an example that is, I think, true for many African countries when it relates to the availability of resources and what the state can do in terms of what is promised and what is actually available. In addition to the regional context, there is a global context as well. So many African countries will also be signatories to international instruments like the International Covenant on Economic and Social and Cultural Rights, which mentions that everybody should obtain the highest standard of physical and mental health. And these protections and legal instruments, where they have been acceded to by various countries or by your country, you are then able to use these instruments in fighting your case at a domestic level, particularly where those particular agreements have been domesticated. In South Africa, given the context of the law and how limited cancer law is, or law that gives rise to access to cancer treatment, we have often had to rely on various laws and legal principles, legal prescripts, to be able to achieve our case or our objective, which is to move the needle forward in terms of cancer care. And so we've managed to use international and regional law in fighting this or bringing this argument to the courts. When it comes to cancer and the law, specifically if we're looking at the South African context, there's no dedicated Cancer Act in South Africa. I know that in some countries, for example, I think in Kenya, there is a Cancer Act or an act that specifically speaks to cancer, or legislation that specifically speaks to access to cancer. There's also very few legislative protections for people who are living with cancer in terms of discrimination in South Africa. However, what we do have is the National Health Act. In addition to our Constitution, we have the National Health Act, and then we also have the National Department of Health, National Cancer Strategic Framework, which provides a framework for cancer treatment in the country, as well as targets on how to best achieve or how to best address the cancer crisis in South Africa. To what extent that has been useful or that has had an impact is very questionable. As we sit, we have thousands and thousands of people who report to health facilities each year with new with new cancer cases that are very far along, so very far in their stages of cancer, which points to an issue in our cancer diagnosis and cancer screening services. So my point is that while we have these frameworks and while we have these institutions that allow us to register, for example, the number of people that have cancer or have had to undergo treatment, there's very little that is done or has been done to address the either the root causes or the screening and diagnosis. As such, the legal interventions on access to cancer care must be based primarily on the right to access cancer and to access health services. And unfortunately, many times that means that we have to litigate on these issues. All right. So I want to go through what we typically look at when we are putting together a case around human rights access to healthcare services, specifically in this context, cancer care. So the facts of a case are quite crucial to the litigation process. The facts of your case will make or break the case. Of course, your case can only be as strong as your facts are. So a lot of the time we spend quite a lot of time looking at the facts and trying to develop the facts to a point where the case is ripe. I'll speak about ripeness just now. But for instance, specifically in this instance, when we were developing this case with Salome on access to Salome and Cancer Alliance on access to radiation oncology treatment, at that point we didn't think that the case was ripe or was at a point where we could litigate and be successful in our litigation because the facts were just not supporting the cause. One would think that if you have a sick patient and you have a government that has a responsibility to provide that patient with services, then it is a slam dunk case that you can go to court and litigate on the basis of that person's rights. But it's not quite so easy. Courts have a aversion to imposing their powers on the powers of the executive or the legislature of a government. So they have quite a separate authority and a separate duty, different to that of the legislature and the executive. And where they feel that the executive could correct issues or could address issues without interfering, they will choose that line of direction in every single case. So what we developed in this case were the facts. So we tried to develop the facts to a point where litigation was no longer a question. It was unavoidable, and we could prove to a court that litigation was unavoidable and that their intervention into what the executive was doing and not doing was paramount. And so essentially, what we did in this case is that we assisted the Cancer Alliance to write letters to the government or to the Department of Health, and we also assisted them to provide the Department of Health with various alternatives on how these people who are requiring cancer services were to be treated or could be treated. When those different suggestions were rejected, it was then at that point where we could say, all right, so we've tried everything, and now we can approach a court. Even at that stage, it became very difficult to approach a court because we had, again, this limited resources question that is in the Constitution. And so we thought, how do we overcome that question of resources? Because a court will say, yes, you've engaged with them. Yes, you've written to them. Yes, you've made the inquiries and whatnot. And the facts at this point to an intervention that is required from the court to make the department solution for this problem. But how are we supposed to say a department must do that when it doesn't have resources? So I'm sure Salome will speak a little bit on this, but we managed to get our provincial treasury in Gauteng to provide funding for these services to be outsourced. And in that way, we managed to overcome the barrier of available resources. So the point is that when it comes to human rights-based litigation, there has to be a multitude of mechanisms that you use in order to advocate for your clients. So initially, your case might be good enough for you to go to court. It might be urgent enough for you to go to court. But where it's not, it is important to create the circumstances that will allow a court to give you the judgment that you need. And that includes building your facts to a point that there is no other option but litigation. And then it also includes motivations that may be made to other government structures for resources and support in order for you to be able to build a case that says this government department has been given resources, this government department has an obligation, and we have negotiated with them to a point of ad nauseum, and we are now in a place where we need legal intervention. And so yes, so at that point, your case will be, as was in this cancer case, will be ripe, which is when the parties have exhausted non-litigious options for engagement in seeking to resolve the dispute, and that the court's intervention is needed to assist to resolve the issues. So to bring a case too early and to bring it too late in the progression of the facts or the story can negatively affect its outcome. And while, for example, in this cancer case, there were many people who were requiring access to critical treatment that couldn't wait, we still had to take the time and take the effort to make sure that we crafted a court case that was beyond beyond reproach or beyond a pushback, right? Where we were essentially in a very good position to get a positive judgment. And that's what we attempted to do. We understood that time was of the essence, and we understood that we had to act quickly. However, we had to balance the urgency of the situation versus building a case that is very strong and that, if successful, will assist not only the people who are awaiting services now, but assist many, many other people to come who might require the same services through its precedent. All right, so there can be more than one issue in a case, and all these issues must be considered in light of the court's previous decisions. This is why it's important to consider why or how the case that your patient or your client wants to bring will affect the existing court's decisions, because a bad case is as bad as bad law, because it creates a precedent that will stick around and harm further patients to come. When an applicant approaches a court, they need to be able to ask a court for a remedy, to the problem that is existing. And the remedy has to be practical. So it has to be something that the court can either direct the government to do, or direct the government to stop doing, or somebody else to stop doing. Or provide some temporary relief for the person who is who is aggrieved. And so typically courts will not want to entertain cases that are theoretical in nature, where perhaps the individual who is concerned has perhaps succumbed to the disease, because those cases are not, the outcomes will not have a tangible impact on the person who has brought the case. And so it's quite important that you bring a live set of facts to the court, and not a more, how do I say, I've lost the word, but not an academic question to the court. And so what that means is that there has to be a level of public participation, and there has to be a level of public support around your case. A lot of the clients and people that we had supporting the cancer case came from hospitals and health concerned or cancer concerned organizations in South Africa, who have patients who are waiting for these services and have been waiting for a while. And so it became quite important that we also do advocacy targeting that group specifically, in order for it to keep the matter live, so that we could keep tabs, or to keep our finger on the pulse, as it were, on what the situation is and how the situation has progressed. Courts approach interfering in, as I've said, courts approach interfering in government execution of its duties reluctantly, and to the extent of reluctance depends, and the extent of its reluctance depends on the nature of the facts before the court. So, for example, a court might be less reluctant to make a finding on a government policy, but more reluctant to decide on a government operations. The court's reluctance can be particularly manifest when the government is actually trying to solve the problem and can show evidence of doing so. So what I mean by that is that, should you get to your litigation day and you are in court and the government stands up and they say, we are actually addressing this problem and we are actively addressing this problem, and here is the evidence to show that we are addressing this problem, the court will be reluctant to involve itself in that matter, or to even settle the dispute between the parties, because of this separation of powers principle and its reluctance to interfere with other government structures. I believe that is the end of my presentation. I don't think I've taken too much time, but I'm happy to take any questions.
Thank you indeed there, Kanye, for an extensive overview in terms of what is actually required when one starts talking about human rights advocacy and how far it will take you if you actually go the whole mile in terms of litigation. Are there any questions directly towards Kanye at the moment? I don't see. Let me just see the chat. You're more than welcome to put your questions in the chat. If there's any questions, please. Kanye, it doesn't seem as if there are any questions at this stage. I wonder if we don't go over to my presentation. Charles, if you would do the honors, please.
Thank you, Salome, and thank you, Kanye, for that session. It was quite informative, and it's a new area that I know has not been fully explored, and I hope this session is going to ignite something further. So we are going to move on to our next speaker. And apologies today, our moderator had a problem with the internet connectivity. So our case speaker is Salome Maya. Salome is a seasoned cancer advocate and activist with more than 30 years of experience in community development and health equity. She is a trained medical social worker and holds a master's degree in research. She serves as a director of the Cancer Alliance, South Africa, and she leads national efforts to secure equitable, timely cancer care as a fundamental human right, building partnerships that turn dialogue into action and championing inclusive, evidence-based policy and research across Africa. She also serves on Medicine's Patent Pool, a community advisory panel in Africa Cervical Health Alliance, and is a member of UNITAID NGO delegation. Welcome, Salome, for the case presentation. Those are your slides.
Thank you kindly, Charles, for that kind introduction. So I'm focusing on equitable, timely cancer care access for all and the evidence-based advocacy embedded in human rights leading to solutions. So I do want to say thank you very much for the opportunity to share my experience as a cancer activist. For over 30 years, I've worked in cancer care, first as an advisor, then as an advocate, and now particularly as an activist. And as somebody has coined it, the 3 A's of cancer activism or advocacy. If we can go to the next slide, please. That's slide number 2 then, okay? As Nelson Mandela reminded us, injustice anywhere is a threat to justice everywhere. Across Africa, we know this reality all too well. Where you live often determines whether you live. And cancer outcomes are shaped not only by biology alone, but also by geography, income, and the health system design. Next slide, please. There is a fundamental difference between equality as well as equity. Equality treats people, everyone, the same. Equity responds to the different levels of need. And justice requires equity. And that is the particular intersection where we as people that are involved in cancer care, where we are at, and especially now in this era leading up to 2030, the Sustainable Development Goals, climate health, all of that. These are the type of questions we will have to ask ourselves. And the question that I'm asking to you is, what is your role in achieving equitable access to cancer care, whether it is locally or nationally or even regionally? Next slide, please. Access to cancer care depends on 4 pillars: availability, affordability, quality, and even acceptability. And across the entire cancer continuum, prevention, diagnosis, treatment, survivorship, and palliation, this has to be applied, those 4 pillars. As Kanye has also alluded to it, the Universal Declaration of Human Rights affirms health as a human right. Yet, while more than 140 countries recognize the principle, there's only a handful explain how they will actually finance this. And then my question to you is, have you truly examined the reality of access in your own country? Next slide. From a South African context, the Cancer Alliance applies a human rights-based approach to advocacy. We are evidence-based, we are transparent, and we're also independent because we do not accept funding from industry. This allows us to speak with an independent and credible voice. But what does it look like in South Africa if we really have to focus on us? We have one of the most unequal health systems in the world. And I actually want you to pause, just for that moment, because I think many people always say, yeah, but South Africa, look at South Africa, they're so much better. But in fact, we are not necessarily. 86% of our population use the public sector, while 14% use the private sector, and they have access through the private sector through 71 medical insurance companies, and yet only 80% of oncology professionals work in the private sector. That means that 14% of the population is serviced by 80% of the cancer care workforce. The impact is vast. Our rural patients travel long distances. Guidelines are not standardized. We have late-stage diagnosis, which is very common, and supportive and palliative care remains limited. Out-of-pocket costs and mental health burdens are high. Next slide, please. Our focus is to document systematic failures and bring them to government and key stakeholders. Since launching our human rights-based advocacy approach in 2016, we have achieved the following: 2 national reports that focus on access to cancer medicines, the use of competition law to challenge inequitable and unaffordable access, and 2 of these cases then are currently before the competitions tribunal. And this also asks for a strong partnership with human rights organizations such as Section 27. And this work is only possible through collaboration. And that is what also is important, that in terms of human rights care access, you cannot do this on your own. Next slide, please. Our research on the cost of cancer and the projected cancer burden to 2030 revealed deep policy fragmentation. Cancer care in South Africa is governed by more than 20 different laws, as well as their supporting regulations. Responsibility is spread across 5 within the National Department of and 9 provinces with very little coordination. Cancer is not prioritized due to South Africa's quadruple burden of disease, and I think that in many other African countries we have a similar situation. We developed a policy brief calling for a National Cancer Institute similar to that of Kenya, Nigeria, and Uganda. And such an institute will ensure national data coordination, knowing that without data, we cannot plan and we cannot budget. Standardized guidelines between both the public as well as the private sector, integrated care pathways, and that will speak into the national health insurance system, accountability, and also research that is aligned with the population needs. Next slide, please. And this is particularly the slide that talks to the work and what Kanye has actually shared with us, that we've used the courts to advance access to cancer care. Our case against the Gauteng Department of Health is indeed a landmark human rights case. We began this work in 2021, and it will only be heard by the Supreme Court of Appeal in 2026. And by that time, it will most probably be the 4th or even the 5th time that we will be in court. In the meantime, patients have died due to system failures. Again, this work requires strong partnerships, rigorous evidence, as Kanye has explained there, as well as a long-term commitment. And I can actually even say that you cannot start this journey if you are not willing to go in it for the long haul, because it is not something that is going to be resolved in one court case, unfortunately. And without Section 27, this case would not have been possible, with the guidance from them, as well as all the supported advocacy that goes with it. Next slide, please. Advocacy must also offer solutions. Our Solutions Lab approach brings together all the stakeholders to create practical reform. And this has led to a national cervical cancer elimination strategy that will be announced by the end of February this year. And we are now also working with one of the provinces on an integrated cancer care model as a pilot to look at how this can be shared within all the other provinces. Our priorities till 2030 is also, apart from the National Cancer Institute, is that we will want to look at a social behavior change communication framework, and that is specifically linked to the elimination strategy, a survivorship framework, because we need to embed the principle, nothing about me without me. The voice, I cannot stress it enough, the voice of the cancer survivor, the cancer patient, that one whose rights have been denied. We cannot walk without them. Next slide, please. Cancer advocacy remains underfunded and undervalued. And I am sure that each of you, where you are, literally will agree with this statement. Much of our work depends on volunteerism, on partnerships, and sustained commitment. Yet the need is urgent. If cancer care is to be equitable and timely, we must strengthen accountability, justice, and the patient voice. And in closing, next slide, please. We still have much work to do. Equitable cancer care is not about charity. It is justice. It is a shared human right, or it is a human right, and it is a shared responsibility. Thank you. I'm going to open up after that presentation to both myself and Kanye. If there are any questions, we still have more than enough time for questions from the floor, from where you are, or even sharing some, I want to say, some experiences and questions that you may have. Doesn't seem as if anybody wants to. You may unmute if you want to ask a question. I don't see any questions in the chat.
I don't have a question. This is Zippy from Kenya.
Hi,
And
Zippy.
thank you, Salome. It's good to see you again for that very powerful presentation. And also thank you very much to Mapipa for her great presentation. I think globally we are almost facing the same dilemmas in terms of cancer being recognized, cancer care being recognized as a human right. We still face challenges. Even in Kenya here, we don't have it well covered in by I still call it National Health Insurance, although it has changed to something else. And I think the issue of nothing about us is very clear. It's very important. We have to work with those who have had an experience, whether as a patient or a caregiver, and caregivers includes even those of us who are healthcare caregivers, to really advocate for the voice of the person. I think when people hear from those who have gone through this kind of a challenge, they're more empathetic and might, we might move the course of having laws and regulation in terms of accessing care, right from awareness, creation, prevention, early detection, treatment, palliative care, and even end-of-life care. So I think we face a lot of similar challenges, and I agree with both of you that we really have to work together, not just healthcare providers, advocates, lawyers, but together with the patients, the caregivers, the community, the people we live with, the people who go through this are very important in us to be with us together to advocate for health as a human right, and particularly to advocate for palliative care as a right, because that's still a challenge in many of our countries in Africa. Thank you very much for your presentations.
Thank you, Zippy. Always nice to see you and being on this forum. And also, I think the intersection where we also need to look at which are the various forums that we where we actually are involved. I actually want to Florence, I see that you are online. Manju, Florence, I'm not sure if you are able to unmute and also look at maybe perhaps how do we involve other structures than ECHO, or the various structures that we have in Africa to promote the concept of human rights-based advocacy. Or is there anybody else that can come in there, because I think that in itself is a very important important way of looking at it. What are we going to do to actually ensure that we start with this kind of work? And maybe I must also just share that from my side. I don't want to take over the stage again here, is that the movement from being in an advisory capacity or an advocacy capacity to that of being an activist, it didn't happen overnight. And you can only move from the one to the next once you've been involved for years within the advocacy space, because you have to be able to base all your work on activism, on evidence, on evidence. However, the role of an activist sometimes can be a very lonely road, because there's many of the cancer organizations and people that are involved in cancer that technically don't want to go into the role of activism. But we've seen in South Africa, and not only just in South Africa, how activism have actually improved access to medicines if we start looking at what has happened within the HIV space. Is Rose still on the call? Rose Gahire. Rose, are you
Maybe
still?
before Rose come on, Salome, can you get me?
Yes, we can. Thank you. Thank you, Mandra.
Just so sorry with the internet connection, but I thank you for stepping in so fast, and I'm so grateful with the presentations that have been done. We are so grateful. And just like we said from the beginning, this echo session is just an eye-opener, because these are some of the things that many organizations or institutions have been going through and they didn't know what to do. And so the first thing is to create awareness, and creating awareness is like having this session that we are having this afternoon, which I see it to be very, very essential. And when you look at the representation here, you see that we are very minimal. We are not as many as what I've loved us to be. So I think that for us who are here and who have been able to go through this presentation, we need to be the ones to take the message along, so that people get to understand, and from there we can do better. So this is one of the things I can say, just encouraging us to, who have heard these presentations, to be able to create more awareness so that people will know exactly what we are talking about. Thank you.
Thank you kindly for that. Yes, I agree. And you know, although yes, we had 34 or 33 participants at one point. And yes, it may not be as many as what we sometimes have, because I think we've had up to 100 participants. And that also, so what you have said there and shared with us is this is just the beginning of creating the awareness that human rights-based advocacy is something or basing our work on the principles of human rights is in fact the way to go. If we start, and one of the things that I particularly am quite passionate about is the fact that if we go and look at Africa, what is our ability to access the latest medicines, personalized medicines, and at what stage will we be able to also share that with our populations? Are we always going to then say, well, we can't afford it, it's too expensive? So those are the kind of things. And then and I'm sure Zippy will agree with me. Yeah, I mean, even if we start talking about access to pain medication, where where is the equity when we start talking about pain medication? Where is the equity when we start talking about access to vaccines? We've got a HPV, a human papilloma virus vaccine. That vaccine is not only just for cervical cancer. It is a vaccine that can also impact other cancers. I understand that we have to focus on cervical cancer. However, that vaccine, and it's called the human papilloma virus. It's not called the women papilloma virus. And those are the kind of things that we need to interrogate and question. Kanye, anything from that you would want to add? Noting that we've got haven't got very specific direct questions aimed at you, but anything that you still want to add? I know also that you are involved in sexual reproductive health. Maybe share some of the intersection there. I know I'm putting you on the spot.
No, okay. I think what I would say is that in all areas that relate to access to healthcare, there has to be a strong community of activists that are willing to go the extra mile and also are willing to go the distance with the work. Because like you said, we started this case 5 years ago. And when we started, we didn't think that it was going to be a case. We thought it was going to be a matter of negotiating with the department and getting them to see sense and getting them to then treat the patients that they need to treat. Then we had some ups and downs. We had some good news when money was allocated and we thought, yes, this is it. These patients are going to be treated. And we were disappointed by the government there again when they didn't spend the money that was allocated. And so in all that time, it could have been very easy for us to say, well, we tried and walk away from it. But it really does take some grit. It takes some bravery. You have to be brave, and you have to be willing to sacrifice not only your time but your emotional capacity as well. As you see people that you've grown to know and to befriend in your closer circles die, and they might not be candidates for treatment at the point that you get the relief that you need. But it is very, very important to form these structures and to understand that the wins are not going to be now. The wins will come later, and the people who you might not know at this point will thank you later. As you said, we do work in sexual reproductive health, but our work there relates to mainly to access to contraceptive care, as well as access to abortion, which I think can be very different in different contexts in the African continent. But yeah, we do a wide array of cases, all centered around access to adequate care in the healthcare space, and access to dignity and a dignified life and existence. Thank you.
Thank you, Kanye. Anyone else who want to come in before we close our session? Because I think even though we still have some time, we can actually close the session. So this was the first session for this year. And as you all know, most of you that are on the call, thank you very much for the fact that you are here. I do want to extend the invitation to you that if you want to find out more or even some guidance, you are more than willing to make contact with me directly. And if I have to link you then with Kanye, I'm sure she will gladly assist or give some guidance if she is in a position to do. But it is something, as the PF said, something that we need to take forward in our structures where we start working. In our next session, you know that our sessions are always on the last Thursday of the month. Central African time, 4 o'clock East African time. I hope I'm right with those time zones. It is always for an hour and a half. So our next session will be the last Thursday then of February, and we will share the full detail of the program. And then Dr. Samuel Umbunyano, who is our lead, our chairperson of our steering committee, and who is actually at the moment I want to say in transit, if I'm not mistaken, between the United States and Sweden, indicated that he does have a comment. So over to you, Sam.
Thank you very much, Salome, for actually stepping in as a moderator and also case presenter, and also having Mrs. Pipa being able to steer this conversation about human rights in cancer care. So as we close, today's session, I've been in and out these sessions, but well and good. But as we close the session today, we are reminded of a fundamental truth that cancer care is not a privilege, it's a human right. Every person, regardless of age, geography, income, or social status, has the right to timely diagnosis, quality treatment, pain relief, psychosocial support, and dignity through the cancer journey. And it's also important to look at, when access to cancer care is delayed, denied, or unequal, it is not just a health system failure, it is a human rights issue. Through this ECHO community, we are doing more than sharing knowledge. We are breaking silos, strengthening capacity, and standing together to ensure that no patient is left behind, especially children and underdeserved populations and those living in low resource settings. Equity, inclusion, and justice must be at the center of every cancer policy, every program, and every clinical decision we make. So let us leave this session not only informed, but committed to advocacy, collaboration, and action, because advancing cancer control in Africa means advancing human dignity, social justice, and the right to health. So thank you for all of you for joining in, and also for your dedication, your voices, and your leadership. And together we through this ECHO program, and we've been existing since 2018, and also being led by a steering committee and a hub in Nairobi. And of course, this year, we look forward to ensuring that we work on the NCCP core elements as the topics at hand. And also, I've seen quite a number of steering committee members also present in this session. And let's continue to turn knowledge into action and rights into reality. So thank you very much, Salome, Mrs. Mafipa, and also the Kenco Hub team for ensuring that this session goes in place. And we look forward to have more engagements and participation in the next sessions to come. Thank you all, and good day, good evening, and good night for some of us.
Indeed. Thank you. Thanks, team. I think we can close. And the recording and the presentations will be on the platform shortly. Thank you, everybody, for attending.
Thank you.